I will show some interesting angiograms with diagnostic and management questions. So this is the first case here. I want you to look at this RCA and tell me what is the true RCA. Point exactly to which one is the true RCA. You see two big branches here. So which one? Is it that one, this arrow, or that arrow? Which one is the true RCA? If you're not certain which one is the true RCA, the better view to delineate would be RAO. However, you should be able to tell on this view already. The RCA on an LAO view, it's an LAO with a little cranial. The RCA is the one that has two bends. It bends here, then it bends again at what we call the crux of the heart, which is where the AV groove meets the inferior septum, which is this point. So I think looking at this view, this is a true RCA. It has one bend here and one bend there, and this is probably the true PDA, which would make this branch an acute marginal branch. It is smooth and straight with no sharp bend distally. That's how an acute marginal looks like. Straight, no sharp bend distally. This is an illustration from another patient. See this artery, smooth and straight with no sharp bend distally. Whenever you see this, this is an acute marginal. It's unlikely to be a true RCA. Here is another view. The RAO view is the one that helps you confirm. And you can see the artery that goes toward the margin of the heart is the acute marginal. The other one that is looping and giving two bend. You see, this is one bend, and this is another bend over here. This is the crux of the heart, and this is the true PDA. This is actually an acute marginal. It's important to know the anatomy. Why? Because this branch has a tight lesion. So one should know, should I fix it or not? If this is predominantly an acute marginal, we generally avoid fixing acute marginals. This is a special acute marginal. It's an acute marginal that feeds the RV, then it wraps below the right ventricle on the inferior surface of the right ventricle and reaches the PDA territory. It reaches the inferior septum. Here's an image. So this is the RCA. This is a standard acute marginal running on the border of the RV. This is a standard acute marginal. It courses on the border of the RV. This is the special acute marginal that eventually takes a turn and reaches the inferior septum and supplies some of the PDA territory. And by the way, this artery, in about 25% of patients with RCA dominance, there are significant anatomic variations in the origin of the PDA. And there is this variation here where you have partial supply of the distal PDA territory by a low-lying, that's what we call it, low-lying acute marginal branch that wraps around the inferior RV and reaches the inferior septum. So this is really an acute marginal. It's important to know in decision-making, because here's the question: do we fix acute marginal, and when do we fix them? So we do not usually do PCI of RV marginal stenosis or non-dominant RCA stenosis that only gives RV marginals, because the RV rarely gets ischemic. RV is thin, is able to increase its transcoronary O2 extraction, which is at baseline 50%, unlike the LV, which is very high at baseline 75% with very little room to increase it. And the RV also easily recruits collaterals because of its low coronary microvascular resistance. So when RV gets ischemic, it's usually because it's thick or dilated, in which cases it's more important to treat the RV hemodynamics than to treat RV marginal disease, like in pulmonary hypertension or big dilated failing right ventricle. So only rarely PCI of acute marginal may be considered. Acute MI with RV shock from acute total occlusion of major acute marginal or non-dominant right coronary. And those are the only cases we fix non-dominant right or acute marginal. Another situation is something like what I just showed, but even what I just showed, it should be exceptional. It's an inferior RV marginal that supplies part of the PDA territory. So it's supplying part of the left ventricle, not just the right ventricle. It's supplying part of the left ventricle. So it can cause left ventricular ischemia, but it often doesn't. So you really need to prove he has very typical exertional severe angina, and you have to have objective evidence hemodynamically, IFR or FFR. Question from the audience. Bottom line, when would you fix this acute marginal in this patient? If he's having RV shock, so he's having STEMI typically with RV shock. In this case, he might have even a little inferior STEMI. So yes, STEMI, or short of a STEMI, I would only fix it if you have this, what I showed, severe typical exertional angina that is otherwise unexplained by any other disease, and prove it is significant by IFR or FFR. All right, along those lines, this is another case. This is a 59-year-old female. She had inferior STEMI at an outside hospital with recurrent VFib and RV shock. She got her RCA stented at the outside hospital, as you can see here. This is the stent. This is an acute fresh stent, but that stent thrombosed during their procedure. She was transferred to another hospital where they reopened it and they placed an Impella RP. And this is what they got, the second operators. I want you to tell me here, why did that stent thrombose? Just by looking at this image. This is their final image, by the way.
Poor distal runoff.
Excellent answer. Be specific. What is this artery? So they put a stent here, and this is the runoff. What is this runoff that you're seeing where the wire is? Again, know those basic rules. This is an LAO view. The true RCA, if it is a dominant right, should have two bends. One bend here and one bend at the crux. Look again. One bend and another bend at the crux. Okay? Two bends. Or here you can see you bend here at the margin of the heart, and you bend again at the crux of the heart, intersection of AV groove and inferior septum. So when you see an RCA that looks smooth like this, beware, you're going into an acute marginal. It could be that this is a non-dominant right and that's all you get, or it could be you're missing the true right. So when you see something smooth like this, this is an acute marginal, whether that's all that RCA gives or you're missing something. So they open the RCA into one acute marginal. Seek, is there a true RCA behind it? And actually the late filling shows you. This was probably missed, but you see late filling here? This is where the true RCA lies. Look again at this point. You see that? So the reason that stent thrombosed is poor runoff. They open that RCA into one acute marginal. They did not open it into the much larger, probably distal territory. One of the big reasons stent thrombose, beside underexpansion and dissections, is poor runoff. And here it's also poor recognition of anatomy. They open into one acute marginal. They miss the true runoff. And here you can do RAO view to confirm that what you see on an LAO view as a smooth, straight structure with no bend is actually an acute marginal. On an RAO view, you'll see that acute marginal running on the margin of the right heart, whereas a true RCA will have bends distally. Along those lines, this is a 71-year-old man. He had full metal jacket of his LAD placed at an outside hospital 2 days before presenting to us. This stent, this full metal jacket, was unfortunately placed for stable CAD. Look at it. The full metal jacket ends here, from proximal LAD all the way distally. Now, just 2 days later, he presents to us with, it's very similar to the prior case answer. No runoff. Okay? Look at here we open that stent thrombosis. The stent finishes here. Look how much runoff you have. So that distal stent is getting flow to a tiny territory. So that distal stent is receiving very little flow. So poor runoff is the cause of stent thrombosis in this patient. You can do IVUS, look for underexpansion and edge dissection, but it's very evident. That's one reason I avoid full metal jackets. You put stents that are way longer than the length of half of the vessel, you're predisposing the patient for thrombosis because the distal portion of that stent is having little runoff, it's having little flow. It will thrombose and the stent thrombosis will track backward. Eventually, the whole stented area will thrombose. Please don't stent vessels proximal to tip. It will thrombose. This is a poor man who had just a stable angina. He ended up with a massive anterior MI. Okay, this is another case. This is a 55-year-old man, type 1 diabetes, prior LAD and diagonal stents. He presents with posterior STEMI. And you can see here an occlusion of that first major OM here. You see the stump. Okay, you see the stump here. So we stented this. And after stent, this is what we have. Very poor flow through the stent and poor flow distally. What's the diagnosis here? The patient also started to have more chest pain. Even though it was already occluded, somehow now he's having more chest pain. So what are the diagnostic possibility and what to do next? How to figure out what's going on? There are two differential diagnoses mainly here. Edge dissection at the proximal or distal edge. And number two, this is a STEMI. He had a heavy thrombus burden. Maybe you're having a lot of distal emboli. They could be macro emboli, plugging major branches of that OM, or they could be micro circulatory emboli, giving you the phenomena called no reflow. So how do you figure out what's going on and what do you do next?
IVUS.
Yes, you can do IVUS. Unfortunately, IVUS, when you have such impaired flow, you have a lot of blood stasis artifact, and it's hard to tell in this blood stasis, is it just blood stasis or is it heavy thrombus? And it's hard to delineate dissections in this. So I didn't find IVUS helpful in cases like this myself. So I gave a talk in the past about STEMI primary PCI, and I describe in the comment section of what to do if after wiring an angioplasty without stenting, wiring an angioplasty, you still have no flow. And I gave 4 ideas. The same ideas kind of apply to this. After stenting, you lose flow. So there are 2 major differential diagnosis, and the management strategy is similar to having no flow after wiring an angioplasty and STEMI. So 2 major differential: edge dissection, proximal or distal, heavy thrombus burden with distal microembolization, no reflow, or macro embolization into major branches. So 2 things you do. The first thing I usually do is I get a small balloon and I daughter the vessel. Meaning with the balloon, I run it up and down without inflating it, just massage the area and see if I reestablish some flow. If I don't reestablish some flow, I try to balloon little proximal and distal to the stented area. The point is try to reestablish flow and try to help me make an angiographic diagnosis so I can see, is there dissection, is there thrombus burden? Because when you have no flow, you cannot tell. The second consideration, so I tried to do that, I still didn't get any flow. The second consideration, and this is the point of this case, consider distal contrast injection via a dual lumen catheter, advanced distally. That's a key tip that doesn't come to the mind of a lot of operators. So you take a double lumen catheter, you advance it over the wire, and you inject contrast distally through that double lumen catheter. And then you will see. So that's what we did. That's the injection through a double lumen catheter. The double lumen catheter is here. So we injected here, and you can see that vessel is filling. There is a little bit of impaired distal flow, but it seems the main issue is here. Look at it. The main issue is proximal edge dissection of the stent. You see a lesion, you see a narrowing at the edge of that stent. So the message is contrast distal injection via dual lumen catheter advanced distally. It may show you distal macroemboli. It may show you no reflow, and this patient had some degree of no reflow, but that wasn't his biggest issue. It may show you dissection planes, and it did in this case. So for this patient, we immediately stented proximally. Another thing you can do with that dual lumen catheter once you see no reflow is you administer distal coronary vasodilator through that microcatheter. And we did in this case. You can administer verapamil or nipride through that catheter, and that will improve the no reflow. But the biggest issue was stenting proximally in this case. And that's what was done, and he had a good result. And for the no reflow, we used distal vasodilator, and we gave integralin as well. Through this case, I want you to know the classification of coronary dissection, iatrogenic coronary dissection. It's an A through F classification. C through F are the most serious one. And here I will focus mainly on stent edge dissection. You can have coronary dissection from balloon, or you can have it from stenting, in which case it will happen at the edges of the stent, as happened in this case, at the edges of the stent, in this case, proximal edge. So A through F. A means a little bit of haziness that clears quickly. B means a line that also clears quickly. C is contrast stain, is that dye that hangs, that doesn't go away. D is a spiral dissection, usually with some impairment of flow. E and F means E subtotal occlusion and F total occlusion. C through F are serious, and I'll show you some examples. When we have angiographic edge dissection, C through E, you definitely need to add a stent at the edge. And be careful, if you have an edge dissection, that means your stent was probably oversized, or you went too high on the pressure and the balloon of the stent dissected that edge. So likely use in this case a smaller size, lower pressure stent to avoid another edge dissection. Now, if you have A or B dissection, back in the era of standalone balloon angioplasty in the 80s, A and B were considered benign over the long term. So those were not a problem. In the stent area, if you have A or B edge dissection, we probably stent it, or at the very least, you need to IVUS and decide to stent that A or B dissection based on IVUS features, which means, does this dissection reach the media and it's over 1 quadrant or more than 3 millimeter long, in which case it warrants stent. If it is not by IVUS feature, it doesn't reach the media, or it reaches the media without any of those two, then it doesn't warrant stenting. And this is a paper that suggests that dissections A and B at the edge of the stent may be left alone, but they do need further assessment, such as IVUS or OCT. In that paper, they left alone most of them. They did FFR. I would do IVUS. But anyway, they left most of them alone, and they did fine, A and B. This is another illustration here. This is a patient who has two LAD lesions that we proved are significant by IFR. This lesion here in the mid-LAD and this lesion here more proximally. So we balloon both lesions and we put our first stent in the mid-LAD and we were ready to put the second stent here. But the patient after that mid-LAD stent started to have chest pain. And this is the angiogram. And I just want to illustrate to you, does everyone see that dissection? You see dye stain here above where we positioned our stent. Everybody sees it? This is dissection type C, that dye stain that doesn't go away. It sticks there. Okay? And it's actually, if you look more carefully, not type C. Initially, it looks type C. It's actually type D. It's a spiral dissection because you see another stain a little more distally. You see another stain here. It's not as pronounced, which tells you that dissection is spiraling down like this. It's starting at one point and it's spiraling to another point. Sometimes you see it on both edges of the vessel. You would see it here, there, and there. You would see stains in multiple places on both edges of the vessel. Here we see it in two places at the top of the vessel, here and a little bit down. It's not a big deal here. This was induced by the balloon angioplasty. We were planning on stenting here anyway, so we did stent it eventually. But I just want you to recognize the angiographic appearance. And after you stent that dissection flap, it looks nice. You may still have a little bit of stain. That dissection flap behind the stent may still fill a little bit with contrast. It will progressively heal. It's not a problem to have a dissection flap behind the stent as long as both edges of that dissection are sealed. I want to show another case. This case was shared by my prior great fellow, Wasawat. So this is a 43-year-old man with no past medical history. He presents with chest pressure that has been going on at rest off and on for the last few days. This is his EKG. What's the diagnosis on that EKG? Could this be pericarditis? This is not pericarditis. This is a STEMI. So we see ST elevation in the anterolateral lead, predominantly in V2 through V5. When you see that, go through the differential. STEMI, pericarditis, early reportization, or secondary to LVH or left bundle. The latter is not there. There is no LVH or left bundle. Could it be pericarditis? I don't think so. This is, in my opinion, definitely an anterolateral STEMI. One hint is whenever you see that STT complex equal or bigger than the whole QRS, that's always very concerning to me. Okay, that's an early sign of a STEMI. So here, look at the SCT in those two leads. It's almost bigger than the QRS. That's very concerning. Another thing is when you have pericarditis or early reportization, you tend to have a big QRS, particularly in early reportization. You do have a big QRS in those cases. Another thing, when you have pericarditis, you have basically diffuse subepicardial injury, and therefore the ST elevation axis is parallel to the heart axis, which is this. So you tend to get most pronounced ST elevation in leads parallel to this, which is lead 2 and V5, V6, and you get ST depression in AVR and V1. Look at this patient. He has ST elevation in V1. When you have ST elevation in V1, it's very much against pericarditis. Also, when your ST elevation, it's not predominant in lead 2 and V5, V6. Again, against pericarditis. It's predominant in V2 to V4. So this is, for all the reasons I explained, this is anterolateral STEMI. They recognized it, and they took him to the cath lab. And this is what the angiogram shows. And this is another view. So what's the diagnosis here? What's the finding? Is there a problem in that LAD? So you can see that this is the LAD here. The other one is a diagonal running on the border of the cardiac silhouette. But you can see the LAD and it's looping. It has a turn here and it goes there and it occludes somewhat here very distally. So there is a very distal LAD occlusion. After it gives those distal septals here, it occludes, which is not surprising. The STEMI EKG that mimics pericarditis is usually an apical STEMI. It's a STEMI that looks into all leads. When you have STEMI of this area, it will involve that part of the heart, that part of the heart. So all leads will have ST elevation. So it will mimic pericarditis. So the STEMI that mimics pericarditis is usually an apical STEMI, distal LAD STEMI. So it fits. It's a distal LAD occlusion. Why did he occlude that LAD? And you should think SCAD. And here are the reasons you should think of SCAD. He's a man that's not characteristic of SCAD, but he has all the other angiographic features. He's relatively healthy. He has no calcium, no heavy atheroma in his vessels, no calcium. His vessels are very tortuous. Look at that, very tortuous. And we know that heavy tortuosity is associated with SCAD. I mean, look at the LAD and diagonal here. They overlap almost because they are so tortuous. And in this view, it's hard to sort out the branches because you have so much overlap. And the disease is very long and smooth. In this case, it's so long, it starts here. It starts here where it's subtotally occluded, then it occludes fully. It's a very long disease, long and smooth distal disease. That's also a SCAD feature. Remember, those are the features. Long, smooth lesions, more than 30 millimeter, heavily tortuous, yet smooth, non-atheromatous vessels, non-calcified, a lot of overlap. Those are the 4 angiographic features. And what type of SCAD this would be? There is a type 1 and type 2. Type 1 is you see in a flap and a stain, kind of what I showed here. This is iatrogenic dissection, but that's kind of what type 1 SCAD could look like. You don't always see a stain in type 1. You see either a double lumen and or a stain, but it would be something like this, except it would be longer if it is type 1 SCAD. Type 2 is where you see that diffuse, long narrowing that is usually distal. And this is what this patient have. And when it's distal and extends all the way to the tip of the dissected artery, we call it type 2B. So this is type 2B SCAD. At least that's the angiographic impression. He's a man. So data suggests, registries suggest that about 10% of SCAD patients are men. So it can happen in men. Don't rule it out just because he's a man. He's a middle-aged man, which fits. And here is a registry, describing the features of man with SCAD. It's fairly similar to the woman with SCAD. It tends to be more physical stress than emotional stress in men, tend to be a little bit younger. So what should you do for this patient here? If you think SCAD, what should be done? Should we wire it or leave it alone? SCAD that is not occlusive, not 100% occlusive, where you have some distal flow, TIMI2 or 3, with no ongoing STEMI on the EKG, is left alone. However, SCAD with ongoing STEMI and impaired distal flow, TIMI1 or 0, we should wire it and try to recanalize it. Because you want to abort that infarct, you want to revive that apex. And this is what was done here. So if you have total occlusion, in a way, it's even a little less important to make an initial diagnosis, as you need to wire it anyway. So you need to wire it when it's total occlusion to abort the infarct. Now, the key is you wire it and you try to do low pressure balloon inflation. That's the key idea. Don't stent it. Beside the fact that, as I explained earlier, you shouldn't stent tip of vessels anyway, they will thrombose, but wire it and balloon it. Even if it was proximal, in SCAD, if it is totally occluded, try to be as limited as possible. If it's totally occluded, wire it and low pressure undersized balloon. Just re-establish flow aboard the infarct. No need to stent if you can re-establish flow. So try to be minimalist, but you have to re-establish flow. And that's what they did here. They wired it and did a low pressure, small size balloon inflation. And they did something else. Because he's a man and there is a question mark about SCAD, they did IVUS. And I want to show you, Wasawat shared with me, those are excellent IVUS pictures. So you see, this is your IVUS catheter here. They are in the true lumen. And you see that here, dark banana shape. Dark banana shape. That is how SCAD looks like. That's how a subintimal plane looks like. Dark crescent shape or banana shape. This is from the literature. This is with OCT. Look how the SCAD looks like. So semi-lunar or circumferential shape or banana shape, well demarcated as in here. Somewhat homogeneous, but it's usually darker deeply. And by the way, when you're doing CTO and doing subintimal crossing, you need to be familiar with that image. Distinguish the true lumen from the subintima. So if you're doing CTO and you're going behind in the false lumen, your IVUS catheter will be here in that banana shape, and you will see usually that intima, it will look white because typically it's an occlusion. So you'll see your catheter here, and you'll see a thick white plaque or band that you're pushing to the side. That's how being in the subintima will look like. You will be on this side with a collapsed white atheroma. These are images of CTO subintimal crossing. So here, the wire went subintimally, and the IVUS is over that wire. So the IVUS is in the false lumen, FL, and the true lumen is that white compressed intima atheroma. This is another case here. Again, false lumen is that dark black one. It could be like in here, crescent shaped, or it could be here round or more circumferentially shaped. And it's compressing the true lumen, the white intima atheroma. That's how you know you're in the false lumen. That black one is the false lumen. The compressed atheroma is the true lumen. This is another illustration. You're in the false lumen with your IVUS and wire, and this is the compressed white true lumen. Those are other examples from the literature of SCAD. This is the SCAD. Again, that crescent banana shape, somewhat dark area. Question from the audience. How do you make a SCAD diagnosis when it is a total occlusion, and do you need to do IVUS? Here I have the hint. So if it is a total occlusion, and 30+% of SCAD have total occlusion, and some call it SCAD type 4, you think of SCAD like we thought here, based on the upstream segments. You know, the upstream segment in this patient had no calcium, they were heavily tortuous, a lot of vessel overlap, the occlusion looked long. So you had all those features. Then in total occlusion, you have to wire anyway. You have to try to wire anyway. And when you wire, you may have further feature of SCAD. You may starting to see a double lumen. You may see a wall stain. So you may have additional features of SCAD. You don't need to do IVUS to prove SCAD. Guidelines try to tell you to avoid IVUS OCT if possible when you suspect SCAD, because IVUS and OCT and extra manipulations can extend the dissection. And there is an 8% risk of extending the dissection by doing just IVUS or OCT. And in registries of SCAD, most patients do not receive confirmation by IVUS or OCT. Less than 10% do. Question from the audience. When it is a total occlusion, does it really matter to make a SCAD diagnosis since we have to wire it anyway? Yes, it's very important to make a SCAD diagnosis, because if it is a SCAD, you can just wire it and balloon it, reestablish flow. You do not need to stent it. Also, SCAD has a very different long-term prognosis. With a SCAD, it will heal, and you may want to document healing with CT imaging at 6 weeks. Also, the treatment is different from atheroma. With atheroma, you need a statin and aggressive risk factor modification, and there is a higher risk of future MI events. Whereas SCAD, statin has no clear value, and dual antiplatelet therapy has no clear value. Probably just aspirin is administered. This is another case. This is an angiogram done at an outside institution. I want you to look at it and tell me what's wrong. Can someone tell me what's the immediate next step? So what's the diagnosis and what's the next step? The huge issue in this angiogram, there is massive myocardial blush. What you see here, this is contrast staining the muscle, the myocardium. And this reflects what? Why are you getting blushing of that myocardium? Basically, this is an injection with a catheter that is occluding the vessel, where the hemodynamic probably do show damping or ventricularization. I have no access to their hemodynamics. But just looking at this picture, I'll tell you, this catheter is occluding the vessel. The catheter is bigger than the ostium. It is therefore occluding the vessel. Okay, and you're having damping or ventricularization on your hemodynamics. And this is what happens when you inject with a catheter that is occlusive. The contrast will stain inside the vessel. It will hang inside the vessel. Then eventually it will stain inside the myocardium. This contrast is not clearing. It will sit around in the vessel. It will sit around in the myocardium. It will not get cleared by blood. And this is an emergency. You see that angiogram, my immediate reaction is to pull out that catheter. They didn't have the right reaction because they kept taking picture, and look at that. More myocardial stain. And those are the 3 steps here. So 1, you're occlusive with your catheter, you get damping or ventricularization. The second thing you get is dye stain in the vessel and in the myocardium. What's the third thing that will happen after myocardial stain? In the next few seconds, what will this patient have if you don't disengage your catheter? Ventricular fibrillation. So that's why when I see this, I jump on the catheter, I pull it out. You have 1 or 2 seconds before he goes into VFib. Yet the operators here, they kept injecting. They took a 3rd shot. Look again. So never do that. So this is what he had. Normally, we have our catheter in a big ostium larger than the catheter. And that, in this case, you will have a normal aortic pressure on the hemodynamics. But if you're in a small ostium, you get damping where the pressure becomes flat like this, maybe even flatter. Or if you're not fully occlusive, but somewhat occlusive, you get what we call ventricularization, meaning the pressure looks like this, like a ventricular pressure. Why? Because your wedge and your catheter now is seeing the downstream myocardium, which you will stain if you inject without disengaging your catheter. Okay? And it implies you have a small ostium or osteal disease or osteal spasm. We see that, for example, even if you don't have disease, if you engage a normal conus, which is a small branch, if your catheter goes into the conus branch and you inject, you'll have the same issue. You will have damping and ventricularization, and you can progress through myocardial stain of the RVOT that the conus supplies, then VFib. But the idea is whatever it is, it could be the true right or the conus. Whenever you see this, it's a small ostium, osteal disease, or osteal spasm. So what should you do in these cases? How do you do an angiogram? So let's say here the operator recognized that issue. He saw he's damped. He didn't inject. So how should he do his angiogram? you can consider smaller catheter. The better answer in this case, the best answer is you disengage and you try to be barely disengaged, barely non-selective. Basically, you make your catheter slightly disengaged. So you're not fully engaged, your catheter is in the neighborhood, okay? This is from another case we did. The catheter pressure was damped, as in here. So we counterclock the catheter and we progressively disengaged it with a counterclock maneuver, and we went from damped to ventricularized here. This is ventricularized because the pressure between the peaks is horizontal, it's flat. So we progress from damped to ventricularized to a more normal arterial waveform here. Then we inject in a barely disengaged position with a normal waveform. So you try to be barely disengaged and you watch your hemodynamics, you make sure they are not ventricularized or damped. So that's the best answer, whether for the left or right coronary. And this is another case where we were ventricularized, engaging the left main. So we did our angiogram with a good waveform while being barely disengaged. You see this? We are disengaged here. That's why you're seeing a lot of the cusp. But we are close to engaged, so we're able to see the vessel. And I explained in one of the talks that how can you be barely disengaged? Sometimes you try to be something like this, but the catheter will fly out. You cannot maintain that subtle position, that fine position of barely engaged, barely disengaged. So what you can do in this case is you can get a guiding catheter, wire the coronary, then disengage the guide. The coronary wire will grab your guide, so much so that you can maintain a barely disengaged position with the wire stabilizing the guide. Okay? So that's the best answer, be barely disengaged. In cases, occasionally what I do something like they did, but I fly it out immediately. So I inject 1 millimeter and I pull it out as I'm injecting. I disengage as I'm injecting. That's what we call the hit and run technique. So I give the blood time to come in and clear that contrast and not stain the myocardium. Now, when it is the conus branch, in the specific case of an RCA with the catheter pointing up, you know you're in the conus branch. So there are special maneuvers for that particular situation. You know you're in conus branch, you're wedging the conus branch, that's why you're damped. So in this case, you focus on getting in the true right. You can just tell by the shape. Memorize, when you see this shape with damping, you're in the conus branch. That doesn't imply small right or ostial right disease. That implies you're in the conus. So in those cases, again, I would counterclock to disengage, then clock to engage while putting more of a pulling tension on the catheter as I'm engaging, more than I did the first engagement, to elongate that catheter and make it point down toward the true right. The conus points up and it is more anterior. So I engage by more clock and more pull to make it point down and more posteriorly. You can also get a catheter that points down. Instead of JR4, AR1 points more down than JR4. You can also get RCB catheter, which points down. Look at this angiogram here and tell me what's the diagnosis just by looking at this. This angiogram, whenever you see something like this with what looks like a long left main, think this is not a left main, there is no left circumflex. So whenever you see a long left main, think this is anomalous left circumflex. The left circumflex is rising from somewhere else. And what I'm seeing here is actually not a left main, it's an LAD. And the left circumflex is arising from somewhere else. Now, where is the left circumflex? What's your next step when you see something like this? How do you prove that there is no left circumflex here? Somebody may tell me, okay, this is a long left main and this is a circumflex here. What I want you to know is two ideas. Prove to you already on this shot that there is no left circumflex. One, do LAO caudal, and you'll see there is nothing going in the left AV groove. And two, you can wait till you see coronary sinus filling. Wait for the venous phase. The coronary sinus is in the left AV groove. So where the coronary sinus lies, the circumflex runs. If you see the coronary sinus path and there is no vessel over it, then there is no left circumflex. This is an illustration of another case where we waited for the late coronary sinus filling in an areocaudal view. And you see toward the end of the injection, here you see the coronary sinus filling, and you see that in this plane, there was no left circumflex running. Another tip I want to tell you, in order to tell you that the circ is absent, I told you you wait for the coronary sinus filling. Another thing you can do is if you have MAC in those old patients, well, the MAC is in the AV groove. So if you see there is no circumflex in the plane of the MAC, mitral annular calcium, then you know that there is no circumflex here. What are the possibilities here? Where is that circumflex coming from? There are four possibilities. One, it's coming from the left cusp, but it has a very separate ostium. That's possible. Usually when this is the case, the separate ostium is very close to the LAD ostium, so much so that some of the non-selective contrast spill will show you a hazy filling of a circumflex. I don't see any here. So when you see absolutely nothing in multiple views and you're filling a little bit the cusp of interest, which is the left cusp here, you're starting to think this is likely a circumflex, not coming as a separate ostium from the left cusp. It's coming totally from the right cusp. So that's the second possibility here. And those are the four possibilities. Left circumflex arising from the left coronary sinus, separate ostia. Left circumflex arising from the right coronary sinus. Left circumflex is occluded, but in this case, you should see some late collateral filling, whether from the LAD or from the RCA, and you would typically see some calcium on the path of it. Okay, it will be very ostial left circumflex occlusion. It's quite unlikely without collateral or calcium. And the fourth possibility, which is very rare, but I've seen it twice, the left circumflex is very small or absent, and the RCA is a huge super dominant, and it gives distal AV groove branches that go all the way up to the left AV groove and gives OMs. So remember, the RCA and circumflex both run in AV groove. RCA in the right AV groove, circumflex in the left AV groove. And they meet somewhere in that posterior AV groove. The longer the RCA goes up in that bottom AV groove, the shorter the circumflex reaches to that bottom AV groove. And you can tell that on all your angiogram. You may have those super dominant right that give 4 PLBs that go all the way up. In those cases, you will have a small circumflex that only gives 1 or 2 proximal OMs, or vice versa. You have a right coronary that only gives a PDA. You'll have a circumflex that gives all the PLBs. And an extreme of that will be the right coronary that is not dominant, that doesn't reach the crux, and the circumflex will give everything, PLBs and PDA. So they kind of meet in that zone. So you can imagine an extreme case, extremely rare, where the right coronary goes all the way up in the AV groove. It goes all the way up in the left AV groove, all the way till here. Unusual, but that's one rare possibility. So typically in this patient, if it's not coming from the left cusp, it's coming from the right cusp. It could be either from the RCA itself, close to the ostium of the RCA, or it could be a separate ostium, usually very close to the RCA ostium. A lot of time, as you're injecting the RCA, you may see a blush into the left circumflex. So here, anyway, we engage it. It's coming from the right cusp, and this is a circumflex. What is the course of that circumflex? Well, first you need to know what are the courses. I gave a talk about that last year, but I'll go over it again. There are 4 potential courses for anomalous coronary in general. It could be interarterial between the aorta, which is posterior, and the PA. The aorta base is more posterior than the PA. It could be posterior course. It could be anterior course, which is anterior to both, or it could be what we call septal or subpulmonic course, meaning the anomalous artery dives in the septum beneath the PA, then emerges and gives its branches. How can you tell the course? The way you can tell the course is an aereo view. What I showed you here is an LAO view. You cannot tell a course in an LAO view. You need to go by an aereo view, okay? Aereo, it will split anterior versus posterior. LAO is very good to tell you right versus left cusp. And it's very important to show you that the circumflex here is arising from the right cusp. So LAO is important to tell right versus left. But the next step to tell posterior course, interarterial, or anterior course is to do an aereo view. That separates anterior versus posterior. Okay? An aereo, if it is posterior, you'll see it behind your aorta. You see a blush usually in the aorta, and you see your catheter in the aorta, and it will be looping behind. As you see here, that is how the anomalous artery will look behind the aorta on aortic or coronary angiography, like a dot or a sharp bend behind the aorta. Interarterial course, the anomalous artery will take a sharp bend in front of the aorta, and this is how it will look on angiography. An artery in front of the aorta with a sharp bend. Anterior course, the anomalous artery will take a long loop or eye in front of the aorta, as you may see here, before it gives its branches. Subpulmonic course, it will also be a long loop or eye in front of the aorta, unlike the sharp bend of interarterial course. But more importantly, the left circumflex is always posterior. So your immediate answer in this case could be to do an aereo view to figure out, but the better answer is we don't need even an aereo view. Left circumflex is 99.99% posterior course. It's an inferior takeoff and posterior course. I proved it to you here with an aereo view. So this is an aereo view. This is your aorta, where the catheter is and where you see some blush, okay? This is coursing behind the aorta in an aereo view. So this is a posterior course. And you can see some faint filling of the true RCA. Because like I said, an anomalous circ or an anomalous left main coming from the right cusp will be usually close to the RCA. So you can kind of fill it non-selectively via the blush. And note that the anomalous left circumflex takeoff is more posterior than the RCA and more downward looking than the RCA. It is best engaged with a downward catheter like multipurpose or RCB catheter. This is another illustration. Again, what's the diagnosis here? I hope everybody in the audience can tell. Long left main. Therefore, this is probably not a left main. This is actually an LAD, and there is no left circumflex. So whenever you see an angiogram with long left main, think that. Anomalous left circumflex. And here, again, you see the anomalous circumflex coming in juxtaposition to the RCA. This is an LAO view. Look at this LV gram and tell me what's the diagnosis. This was done at an outside institution. They didn't give a lot of contrast, but you can already tell the diagnosis here. So we're doing LV gram in an aereo view. Aereo view is looking in this direction. It shows you the long axis of the LV and separates the anterior wall, apex, and inferoseptal wall, the wall that is sitting on the diaphragm. That's the inferoseptal wall, which is where the PDA runs. Okay? Now, it's 2D imaging. We don't see the posterolateral and inferolateral portion of the LV. We don't see that part here on the left margin of the heart. LAO view, on the other hand, will show you right versus left and will show that posterolateral lateral margin of the heart. LAO shows right versus left. RAO shows anterior versus posterior, ventricles versus atria. Atria will be here, ventricle will be here. Ventricles here, atria in the back. RAO, anterior versus posterior, LAO, right versus left. But anyway, this is RAO and this is what it shows you. So I'll go back. So you can tell on this view, the antero apex looks okay. There is specifically a mid-inferior akinesis. It's actually mid-inferior aneurysm. That's why you see dye stain. It takes a while for the dye to clear. It's an aneurysm. It's bulging in both systole and diastole. That's what aneurysm is. It's a small mid-inferior aneurysm. But the reason I'm showing this is you can tell which vessel is occluded. That mid-inferior akinesis actually implies obtuse marginal. If it was PDA, it will involve the base and mid-inferior. But this isolated mid-inferior or isolated mid-LV akinesis, whether mid-inferior or mid-central LV akinesis, implies OM. And here I will show you. Because you can see, even though you don't see the lateral wall, when it's akinetic, you can see its projection. When it's akinetic and bulging, you can see its projection. But it will be in this area, in the middle. And this is what this patient had. He had an OM occlusion. That's what caused that akinesis. This is an inferior OM territory. So you get that bulge in the mid-inferior wall. If this was a more proximal OM, you might have seen a bulge in the mid-anterior territory. Something bulging and a double shadow behind the anterior wall. So double shadow bulging behind the anterior wall or double shadow bulging behind the mid-inferior wall, that is usually circumflex OM disease.